much for joining us today. I'm Lady Angelia Hawkins from Jacksonville, Florida, representing the Union St. James and United Baptist Church and the Citizen Scientist Advocate Work Program.
Awesome. So we're going to get started today in our conversation, and Lady Angelia will tell you a little bit about the Care to Citizen Scientist Project, which we are a part of.
All right. It's a joint project with the University of Florida, which is have a long tradition of engaging and working with patients and families, and they initiated this work for the Cancer 2 project in 1988, and it includes investigations into children's health, and the Citizens Sciences program was expanded, and this approach was to engage the community, which a lot of you here today is our community members in Florida and in South Carolina, California, and that you may be not aware of specific health conditions, but that's what we're here today to help you understand pancreatic cancer. And we have some other co-worker scientists that's going to do other breast cancer and other cancers throughout the rest of the week. And we should be able to share them with you all very soon.
Awesome. Thank you, Lady Angelia. All right. So now let me introduce our speaker for today. We have Dr. Sherise Rogers, who received her bachelor's degree from Cornell University in 2009 in human development, with a major in biological studies. And then she obtained her medical doctorate in 2014 and master's in public health in 2015 from New York Medical College. Dr. Rogers also completed her internal medicine residency at Stony Brook University Medical Center in New York in 2017. She completed her hematology oncology fellowship at Ohio State University Medical Center, where she also served as a wellness chief fellow in 2020. And aside from her educational achievements, Dr. Rogers has a passion for mentoring and has completed many professional development programs, such as Physician Leadership Academy and Medical Journalism Effective at the ABC News Medical Unit in New York City. Her peer-reviewed publication presentations have concentrations in gastrointestinal oncology, diversity and inclusion, physician wellness, and strategies to address burnout among hematology and oncology trainees. She is a member of many professional memberships, such as the ASCO and the AACR. Dr. Rogers' area of clinical and research focus are gastrointestinal malignancies with a special interest in pancreatic cancer, the microbiome, accumulating tumor DNA, and cancer disparities. Mm-hmm. And today I would like to present to you Dr. Sherise Rogers.
Mm-hmm. Thank you. Can you all hear me very well?
Yes.
Yes.
Okay, awesome. It is my utmost pleasure to talk with you all today. I'm so excited to talk about pancreatic cancer. And I hope you guys are excited just as well to learn a little bit more. I think it's definitely a topic that people have a lot of questions about, don't really know much about. And there's a lot to learn from everyone, and especially in the research space. So I'm going to talk, but, I really want to hear from you guys too, because, I'm not, as a oncologist that treats pancreatic cancer, and as a researcher, looking for new ways to treat pancreatic cancer, I want to know what the community needs. So, and I want to know what questions you have. This helps me to be able to better educate the community about pancreatic cancer and to make sure that we're addressing the needs of people. So please feel free to honestly, I haven't been to you guys' meetings before, but I'm comfortable with you guys unmuting or putting in the chat some questions as we go, because I want to make sure everyone gets the most out of this talk today. So without further ado, I'll start. So one of the big things about pancreatic cancer is just the fact that what most people have heard about it is that it's, to be frank, it's terrible, right? We hear that people die from this when they get this. It is the third leading cause of cancer death in the United States. And it's expected to be the second leading cause of cancer death in 2030. So if you look at this graph at the bottom, you can see here in terms of deaths in 2020 in regards to pancreatic cancer, it's about evenly split between men and women, but the cancer deaths are, it's about 50,000 in the United States. And of note, our people are the most affected. Blacks have an increased incidence of pancreatic cancer in comparison to other racial groups. And it depends on the population, but some studies suggest 50 to 90% increased incidence. So we're getting it, and the fact that we're getting it means that our, our offspring, our kids, our future generations have increased risk of getting this cancer. And we'll talk more about maybe why that is. As discussed, men and women are getting it about evenly. And the peak incidence, meaning when the age at when most people get diagnosed, is between 60 and 70 years of age. However, there's people that get it way younger and people that get it way, way older. This graph here talks about, is a demonstration of United States. And as you can see, the darker the color is, the higher the amount of people who have it. So if we look on this side on the right of estimated cases in 2022, California and Florida have a big amount of cases. You see Texas here is also, there's a lot of cases in Texas and New York. As you probably also have heard, it's often diagnosed in later stages, especially in Black people. We are being diagnosed much later stages. And part of that is due to its what we call asymptomatic nature in earlier stages, meaning not really having symptoms early on. And we'll talk about symptoms and things like that in my presentation, but that's part of the problem. And what I want, if there's anything you get out of this talk, is that if you have a symptom or that any of the symptoms that I'll go and discuss, it's really important that you get checked out properly, okay? And another major point is that currently, at this time, the chance of cure of pancreatic cancer is highly dependent on if a person can get to surgery. And surgery is dependent upon an early stage of detection. Once the cancer has spread to many places, surgery is generally not an option for most patients. We have to catch it early and mainly in stages 1 and 2 before for patients to have a chance at cure. This is data from the American Cancer Society that looked at how long do people live, other known as survival rates of pancreatic cancer. And these are the 5-year survival rates. So localized means generally means about probably stage 1 or 2. So these are kind of different terms that we use interchangeably depending on where the data is pulled from. And they're using a database called the SEER database. So patients that are found at the earliest stages. About 42% of them live about 5 years. When we talk about regional, that's generally about it. You can think of that about a stage 3 patient. So these are patients who have cancer in their pancreas, but may have some in the lymph nodes around their pancreas too. And they live longer. 14% live 5 year. And then distant, you can replace that with stage 4. And I'll go into detail about the staging as well in a few future slides. And that survival is much less, and that's a 3%. And then when they looked at it all combined, they reported 11%. So what is the pancreas? What is this organ? A lot of people don't know even where it is in the body. So I'm showing this photo here. It's anatomically a human being here. This is the right side of the body. So everything is kind of flipped when we look at anatomy. So this is your right side. Can you guys see my cursor?
Yes.
Okay, perfect. So this is the right side of the body. This is the left side of the body. So you have your liver here. It's right under your diaphragm, and that's on your right side. On your left side is the stomach, outlined right here. So everything is kind of shadowed. The pancreas is this yellow organ here. And the pancreas is interesting because it's not in one plane. What I mean by that is, if we kind of look towards this insert here in the square, the head of the pancreas actually is kind of up front. If you can see where I'm pointing at right here, it's more towards like the top of the what most people call the stomach. But when it sits in the body, it actually points towards the back. So this tail, it kind of angled towards the back of the body. And the reason why this is important is because depending on where the cancer is located, you can have back pain actually, or you can have stomach pain, what people call, the front of their belly. So that's an interesting thing to note. So back pain, stomach pain, unresolving, weight loss and other symptoms I'm going to mention. It's really important to note about this. In terms of the anatomy as well, the head of the pancreas, it sits right in this hook here, and that's the small intestine. So you can also see this green thing here. This is what we call one of the cystic ducts, and that goes into the gallbladder. So if you can imagine, actually in the body, this stuff kind of just sits really close to each other. And this is all important here. You can also see at the top, it's really light, but this is a blood vessel. These are blood vessels that help provide, blood supply to the pancreas. And there's also nerves and things like that. And this is important for when we talk about surgery. Going to this slide, this is just a bigger picture that I wanted to highlight here. And we talk about the pancreas in really 3 important anatomical parts. And this is the head, the body, the tail. As I mentioned, the tail points towards the back. And what does the pancreas do? I get this question also a lot. And this is important because if one does get pancreatic cancer, these 2 things are affected, as well as if one gets surgery for pancreatic cancer, these 2 things are affected. So the pancreas really controls our insulin production. So whenever, I know we all probably have someone that we know who has diabetes, and insulin is affected. This can be disrupted because, as I go back to this slide here, if there is a mass in any part of the pancreas that's really producing insulin, you can have issues with the normal production of that. Secondly, it secretes pancreatic enzymes. And these enzymes are really important for our digestion. So anytime we eat a meal, especially anything that has any fat content in it, We obviously we eat some food, we chew it up, we make it, we chew it into small pieces. It goes down our esophagus. Let's see, it goes down our esophagus here. It's our esophagus. Then it goes into our stomach, right? And then after it goes into our stomach, it goes into the small intestine here. But what's really cool is that the pancreas, it secretes, there's this kind of duct that you see in the middle going through it. It secretes these enzymes. So as food is going into the small intestine, food is being broken down into micronutrients so that it can go to all the cells in the body to provide energy and fuel for the body. So when we can't break down food properly with pancreatic enzymes, we tend to lose weight, because so you can have people who are eating good amounts of food and just the weight does not stay on, because the body, it's basically ends up coming out of the stool because the body cannot break down the nutrition that we need into element that the body recognizes as a resource, because you can't digest it. So many patients will need to take oral enzymes as a substitute. Just like if you develop diabetes as well, you would take potentially insulin to replace that function that the pancreas is not performing properly. Okay. Next thing I wanted to talk about quickly is the types of pancreatic cancer. The main type is adenocarcinoma, which is the one listed. About 90% or more of patients who say they have pancreatic cancer is adenocarcinoma. There are 4 other types and maybe some even more rarer subtypes. Those are, some of them are treated much differently. In particular, this type, very, 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 very different from this or the ones mentioned below. This one generally is much rarer and generally has a much better prognosis than this type. And this type, adenocarcinoma, is the one that I'll be talking about today only. Okay. So we talked a little bit about symptoms, but I'm going to go into more detail. So yes, symptoms, it depends on the location of the pancreas tumor. So when things are at the head of the pancreas, you tend to have more of that stomach pain, also known as more of that stomach pain. You can also have jaundice. Why? Because it can affect the bile ducts. So all the bile and things that are trying to be released from the body can be blocked because of the mass pressing. If it's in the body, you can start to, in the tail, you can start to get back pain, and you can also have stomach pain depending on what part. In the tail, because the tail is located on the left side of the body, some people can have more of a left-sided pain. As mentioned, weight loss, floating stools, nausea, and early satiety. So weight loss could be in pancreatic cancer. Several things can cause weight loss. That could be because of the enzymes I mentioned. Pancreatic cancer is just unique to many other cancers. It just really feeds off of like the already established nutrition of patients. You can have floating stools, and those floating stools are caused by the fats not being absorbed because they can't be broken down. So patients can notice that when they have a bowel movement, the stool, instead of kind of like sinking, it's actually floating at the top of the bowl and you can see that it's greasy. Nausea and early satiety is just getting full very soon, more like earlier than you would expect, only able to eat small meals. Usually you see that more in advanced disease. And these are kind of, unfortunately, the signs that's when people start finally, especially our people, unfortunately, a lot of times start coming when this stuff has weight loss is like a lot, they're really sick, they're really in pain. Instead of maybe some of this early detection stuff, when you start feeling more subtle signs like pains that are really unusual. Okay, sorry, I see the chat. Just wanted to make sure no one had a question. Another thing in terms of symptoms of pancreatic cancer, patients who get pancreatitis frequently. There are some genetic diseases that predispose people for pancreatitis, but there's other things like alcohol use, heavy alcohol use, and sometimes high cholesterol, things like that can cause pancreatitis. It's just the chronic inflammation of the pancreas can make it start forming mutations and increasing the risk of pancreatic cancer. There's also new onset diabetes is one, especially in patients who are much older. If you've never had diabetes before and all of a sudden, it could be a sign that your pancreas is not working, but also there's a reason why your pancreas is not working. And that could be, a very subtle sign that maybe more people should really start paying attention to. And I think so. The next thing I wanted to show you guys is how does pancreatic cancer start? So as I mentioned before, there's the enzymes that the pancreas releases as well as the insulin. So this can actually be described in two parts. The endocrine cells, these are cells that are graphed here, and the exocrine cells. The exocrine cells are the ones that secrete these enzymes, and the endocrine cells are the ones that secrete hormones, insulin, among those hormones. These exocrine cells, they secrete that into the duct. And remember, I told you the most common type of pancreatic cancer is pancreatic ductal adenocarcinoma. So this type of cancer generally forms within the glands and the ducts of the pancreas. Other cancers, such as like the neuroendocrine cancers that I talked to you about, generally involve the other cells like the endocrine cells. So how is pancreatic cancer diagnosed? So it kind of depends. There's a few things. So if someone comes in with kind of the classic pain or jaundice, that's like the yellowing of the skin and things like that, the urine becomes like really dark, all of those symptoms, especially pain. Many people do go to the emergency room for pain such as that. And in the emergency room, a CT is done. So that could be the initial thing that's done that shows a mass. After that, we definitely do full CT imaging that would include looking at the entire body, using the chest, abdomen, and pelvis to evaluate any extent of potential spread. But the gold standard, what we always have to do is we have to get a biopsy. And that's what we call a tissue diagnosis. We never lay our hats on just what we see on the scan. The scan maybe gives us an idea of what things look like and where things are with CT scans. But we have to get a biopsy to confirm what it is. Because remember what I told you, there's so many different types of pancreatic cancer. It may not be pancreatic cancer. So we always have to get a biopsy. And we usually do that if it's only something in the pancreas that we see on the scan. We generally do something called an EUS guided FNA. And I'm going to explain all these fancy, acronyms, what they mean. So yeah, we always need a biopsy. And another thing I wanted to tell you first about that too, is that the biopsy not only tells us what it is, but it allows us to do genetic testing on that tissue sample that we get. So we're able to then tailor the therapy and the treatment for individuals. So that's really important. And the other thing, it does give us prognostic features, tells us how how the cancer may behave and tell us more about the prognosis. Okay, so this EUS, it stands for endoscopic ultrasound. And I have some pictures here to show how it's done. So you guys are now familiar with the pancreas and the anatomy here. So you have to think about, how do I get there to get some tissue to get a diagnosis? So it's a special endoscopy in which someone is sedated. So they're usually given some medication in an IV to make them sleepy so that they don't feel this tube coming down their esophagus that goes in, as you can see on the right side. This is a closer up view that goes in and sticks a little needle here out to penetrate this mass that they see. It's an in and out procedure and relatively safe procedure. And we're able to really diagnose patients just by this alone. In contrast, if there is a patient who we see many things on a scan, like masses in the lungs and the liver, suggesting something, cancer that has spread, it might be easier to do a biopsy of a liver spot or a lung spot versus having to put someone under, some anesthesia to do this procedure. Either way, we need a tissue diagnosis, but in the cases of kind of spread out disease in multiple places, many times we'll do another location like the liver or the lung. Okay. So the next thing I wanted to talk about is, how do we treat pancreatic cancer? And I think the most important thing that you can probably take from this talk as well, if you know someone with pancreatic cancer or any type of cancer, is most cancers nowadays is a very multidisciplinary approach, meaning there's multiple types of doctors who specialize in multiple things, multiple doctors specialize in one thing, and they work together to create the best treatment for a patient. I work at University of Florida, so it's an academic medical center. Most academic medical centers, not all, but most academic medical centers really do have a multidisciplinary approach. Some non-academic centers have them as well. But I really encourage folks to find a place where the doctors really talk to each other, because from the patient perspective, that can be extremely difficult. And while you're already sick or have a loved one that's sick, to have to deal with that, it's very, very stressful. So it's really good to really investigate that up front to make sure that the doctors talk. So in the management of pancreatic cancer, there's generally, if it's an early stage cancer, you'll definitely have a surgical oncologist involved. And that's a doctor who specializes in treating cancer with surgery. You may also have a radiation oncologist, and that's a doctor who specializes in treating cancer with radiation therapy. And then a medical oncologist like myself, who can treat patients with cancer with chemotherapies, immunotherapies, targeted therapies. And then you may see a GI doctor, or other known as a gastroenterologist. And those are the doctors that do those EUS biopsies, like I mentioned. But you'll also have, this is just even an abbreviated list, a radiologist. Those are the doctors that specialize in reading the CT scans. We'll have pathologists. Those are the doctors that read the biopsies and tell us other doctors, what the heck this is that the patient has. So we all work together to really take care of the patient. Another unique feature is at academic centers, and many of them, is tumor boards. Tumor boards are usually weekly meetings or bi-weekly meetings in which all these doctors get together and discuss these these cases so that everyone's on the same page about what the plan of care is. Okay, so let's talk a little bit about staging. This is a confusing slide. I know, nothing for anyone to memorize, but to give some perspective about how we stage pancreatic cancer. So this is more of, and there's two different staging. First off, there's two different staging ways we use. So one of them is more of a surgical staging, and that's best determined at the time of surgery. And that's what this slide looks at. So here, you may have heard of what we call TNM staging. The T part talks about really how big the tumor is. The N talks about how many lymph nodes are seen. And M talks about any distant metastasis, so cancer that looks like it went somewhere else. We calculate, we basically calculate, okay, what's the T, what's the N, what's the M, and we decide what type of stage that is. And with pancreatic cancer, that's generally this type of staging with the TNM can really only be 100% definitive is at time of surgery, because you can't really tell if the lymph nodes have cancer in them until you take them out. However, what is probably the most important type of staging is what we call more of a clinical staging. And this is a staging that we often talk about at tumor boards and with our discussion with the surgeons about, and that is basically, can we get this out? By the looks of it on the CT, can this thing come out? And we define that in usually generally by, is it resectable? Meaning we look at it now and the surgeon thinks that it can come out. We also, the second category, which is missing on this slide, is borderline resectable. So it looks like it can come out, but there is like a vessel in the way, like a blood vessel in the way that's really close, but maybe this can come out. Locally advanced is a clinical stage in which all the kind of blood vessels are a little too close for comfort, and taking this out would not be easy, and it's less likely to come out. And metastatic is when the cancer has spread to multiple places. Yeah. So curative surgery, is there someone on the chat? Oh, does every case go to tumor board? At my institution, pretty much almost every case goes to tumor board. So that's a good question. And then someone asked, why is there fluid buildup with pancreatic cancer? That's a really good question. So that could be, there could be a couple of reasons why that happens. And the reason is, pancreatic cancer patients have a lot of protein buildup. Protein loss, protein loss. And the protein loss, unfortunately, we need that protein in our blood vessels to keep the water in. So in our tissues. So when we have protein loss, the water leaves the blood vessels and goes into the tissues. So that's how people get edema and swelling. So it's very common for that to happen. Yeah. And I realize there's an error on this slide here with the percentages regarding the curative surgery at diagnosis. This is all flipped in reverse, so I apologize by that. The metastatic patients, it's very, very few of them are able to get to curative surgery. Okay. Again, I wanted to emphasize that pancreatic cancer is usually a multidisciplinary approach: surgery, chemotherapy, sometimes immunotherapy, sometimes targeted therapy, and then we also have clinical trials, and that's really important. Okay. In terms of treatment, pancreatic cancer is what we call a systemic disease. And this is what a lot of people, I think, are really appreciating in my field these days. So we tend to proceed with chemotherapy first. And so let me break that down for you. So systemic disease means it's not just involving the pancreas. And what I mean by that is pancreatic cancer cells, each individual cell is microscopic. So even though we may not see something on a CT scan, which would be like, in order to see anything on a CT scan, probably takes like billions of cells, right, to actually see something. A CT scan, even though our scans are getting much better and better, and they can detect things that are less than a centimeter and just a few millimeters, they can't see microscopic things. Neither can surgeons. No one has that type of vision, right? So because, and the reason why we know it's a systemic disease is because the recurrence rate of pancreatic cancer, meaning the cancer coming back after surgery, is still pretty high. Patients who have surgery for pancreatic cancer live on average about 2.5 years after their surgery. So when I do say cure, it's kind of like a double-edged sword, right? Because it depends on how you see cure. Medically, if a patient has no evidence of cancer at a certain point, they're cured. But how long they're cured, that's a different story. So the outcomes of pancreatic cancer is still quite poor. That's why we definitely need many more interventions. So the part about proceeding with chemotherapy first, so even if we know we can get a patient's tumor out, whether they're in the stage 1 and 2 category or clinically, like I was talking about, resectable or borderline resectable, we proceed with chemo first because we want to have the chemotherapy treat and get rid of any of those microscopic cells that we can't see. Okay. So the next thing I wanted to talk about is surgery, the types of surgeries there are. For most tumors in the head and head of the pancreas, we do something called a Whipple procedure. And then tumors in the body or the tail, we do a distal pancreatectomy. And we also take out the spleen. If there is a very large tumor involving the entire gland, some surgeons will do a total pancreatectomy. However, that is a major surgery. I mean, all of them are major, but the entire gland means that the patient has no ability to regulate their insulin, to break down foods and things like that. So it can be a very rough surgery. So this is a diagram of the Whipple procedure. As you can see, the dotted lines is what basically essentially gets removed and reattached. So even part of the stomach is removed and reattached with the small intestine here. And this is a distal pancreatectomy. So pretty much the kind of tail area, you see the tumor here and the spleen comes out here. I wanted to quickly talk about immunotherapy, and someone just asked about that too, so I'm getting to that. So unfortunately, like many other cancers these days, where you've probably seen commercials for drugs such as Keytruda or Opdivo, which have really changed the landscape of treatment of cancer in the past 5 years or so. Those agents alone are not effective in pancreatic cancer. So the immune system, we think, is very suppressed in pancreatic cancer. And one of the areas of research is looking at how we can activate the pancreatic cancer to be more susceptible to immunotherapy. And there is clinical trials in the works right now that are trying to improve that. There are a few exceptions where immunotherapy does work, and those are patients who have high tumor mutation burdens or have something called MSI high, but that's quite rare. I would say very, very small percentage of patients have that. And then targeted therapies. At this time, we have pretty much two FDA approved targeted therapies for pancreatic cancer, and that is for BRCA 1 and 2. Sorry, I missed the 1. So that's the BRCA2. You probably heard of that mutation in breast cancer. So it's initially found in breast cancer. It's called the breast cancer 1 and 2 mutation. But the BRCA mutations are actually not only found in breast cancer, it's found in ovarian cancer, it's found in some prostate cancers, it's found in pancreatic cancer. So we do have a drug that is useful with patients with those mutations. And NTRK fusion patients with that, we have a targeted treatment for. And these are pills. They still have side effects too, but they can be used as targeted therapies, and they work really well. So that's why that biopsy and that mutation testing that I mentioned before is so important, because that's how you find out that information. And in terms of the research aspect, clinical trials also are studying different targets. So that's how we really forward the science to see if there's other targets that are useful in pancreatic cancer. Actually, only 4.6% of patients with pancreatic cancer actually enroll in clinical trials. There's much less Black patients that are enrolling in clinical trials. And again, like I mentioned, this is how we advance the field. Not only in clinical trials, another thing that I wanted to mention is biobanks. So biobanks are a lot of times many researchers will want to collect maybe an extra sample or ask for additional biopsy or collect stool or urine, which is some of the things I'm collecting for my research. And what they're trying to do is to look for different markers, things that we just don't know about yet for pancreatic cancer. And many Black patients are not involved in these biobanks. Understandably so. There's been so much racism and destruction and harm done to our people over time that there's a lot of distrust with this research. Things have changed. And I think talks like this help me to be able to talk to our people about the research that's going on and how we need these samples to be able to study things. Because as it seems like of now with most of these clinical trials, you look at the demographics and they're all white patients. So remember what I told you in the beginning, like we're the ones that are getting it, right? So the most. So how do we know that these drugs actually work for us? So the only way we can know is if we participate. So I really encourage, if you have an opportunity to participate or donate your tissue from a biopsy or things like that, or a family member, that it's really helpful for future research. Tumor markers. So you may have heard that there's certain things you can look for in the blood to look at for cancer. So there's something called, for pancreatic cancer, CA19-9. It's a fair tumor marker. There's other cancers like prostate cancer where their tumor marker is excellent, meaning that it really corresponds to how, if you have the cancer or not, and it also tells you how the cancer is doing if you have the cancer, whether the treatment's working. CA19-9, I always order this in my patients, but it's not a perfect test, meaning there's other things that can affect it, such as infections, things like that. And there's also a group of patients who don't even secrete it at all. So it's not a perfect test, but with patients who do, make a CA19-9 when they have pancreatic cancer, it can be useful to monitor over time. Okay, and then diet, I see the questions, I'm gonna get to those too. I'm almost done wrapping up. Diet and nutrition. So we talked about pancreatic enzymes, most patients will need that. Diabetes management, a nutritionist. Low fat foods is important, and soluble fiber is important as well, and high pectin foods like applesauce and bananas. But I really encourage patients to see a nutritionist if they have pancreatic cancer. Okay, so some signs you should know about, and this is straight off the Pancreatic Cancer Action Network. This, if you have a family or friend or yourself, or you're just so motivated and want to know more about pancreatic cancer and want to be active and volunteer, definitely sign up sign up on their website for information. They have a lot of resources for patients and families. But here, symptoms, I went over some of this, but definitely want to go over it again. I think it's so important. Abdominal pain, nausea, loss of appetite, jaundice, weight loss, changes in stool because of the fat not being broken down, so oily and watery, and new onset diabetes. Risk factors. So this is always an interesting topic because people want to know how they can decrease their risk. So this is first is family history. So anything involving patients who have strong family histories or genetic syndromes, and I'll talk about that as well. Diets high in red meat, processed foods. In contrast, a diet high in vegetables and fruits can decrease your risk. Obesity, increased risk. Some of these are pretty universal, honestly, with most cancers. Obesity, sedentary lifestyle, red meat levels, smoking. People think of lung cancer only with smoking. That's not the case. Smoking increases your risk for many cancers, including pancreatic cancer. Many patients, that's the only thing that I can pick up. Increasing age, long-standing diabetes, generally over 5 years, can increase your risk, and chronic pancreatitis, like we talked about. And then I know you probably talked and heard about pancreatic cancer disparities. So we know about the disparities in incidence, but there's obviously also, unfortunately, and I probably don't have to tell you guys, there's disparities in outcomes. Black patients are getting less surgeries. Black patients are living less than our white counterparts, and that's so multifactorial. There's no specific reason I can say pinpoint. Somebody might say, oh, the disease is worse in general. It could be that the place where they live. It could be overt racism. It could be the patient's not offered all the opportunities. It could be the patient doesn't have the resources. There's so many reasons. And that's why I think that these forums are important, so that we are all aware. So in terms of risk for pancreatic cancer and like genetics, there's only about 10 to 50% of cases are attributed to genetic causes, and 5 to 10% of individuals with pancreatic cancer have a family history of the disease. There are 2 categories of risk, and that's genetic predisposition, and then there's familial pancreatic cancer. So that's just having a pair of affected first-degree relatives. So that's like a parent, a sibling, who do not have like a known gene, like for example, the BRCA1 or BRCA2 mutation, but just have this long family history. So if you do have a long family history, I do recommend going to see a cancer genetic counselor. Specifically, I emphasize the cancer genetic counselor part. But even if you go and they don't find specifically a gene, which does happen, that still does suggest that you can be tested as a high-risk person for pancreatic cancer. These are the genes that we know of that increases risk for pancreatic cancer. I told you about some of them, the BRCA genes, but these are a whole bunch of them. So that's why the genetic testing is important. These are some risk ratios for some of the things that increases risk for pancreatic cancer. We kind of talked about that. One thing I didn't mention is high alcohol consumption, more than 6 drinks a day. Increases risk. We talked about new onset diabetes and type 2 diabetes for long-standing amount of time, active smoking, and BMI greater than 35. So as you know, for some cancers, we have screening that everybody does, right? For colon cancer, there's screening that everybody does. But if you have a family history, you usually start earlier. For pancreatic cancer, there's no really good screening test for everybody. So we really don't have like and plus we don't have a perfect test that really helps identify that. So we really do targeted screening for patients that are high risk. Again, family history, some of those risk factors I mentioned. Another thing is pancreatic cyst. And most people wouldn't know that they have a cyst. Usually that would only happen if you had a CT scan for something else and they found it. So those are the some of the reasons to be screened early for pancreatic cancer. There are plenty of institutions that do this type of just high risk pancreatic cancer screening. So I would just go and Google if this kind of situation pertains to you and see where they have them at. A lot of them do telemedicine visits. I was just talking to a colleague earlier today who has that. And also I'm going to be trying to establish a early detection clinic here at University of Florida. For this is a lot of stuff on this slide, but the sum of this is just saying that we can do those EUSs that I showed you on the picture of for biopsies. And we can do special MRIs to look for pancreatic cancer early. And we do blood work and things like that. I mentioned the Pancreatic Cancer Action Network here. They're actually having a talk on June 22nd at 2 p.m. Eastern Time, 11 a.m. Pacific Time. And they're talking about pancreatic cancer in the Black community. So if you are really interested in that, I recommend that you listen in on that event. I think I said this a lot. We're trying to discover novel ways to treat pancreatic cancer. One of the things you may have seen in the news is circulating tumor DNA, and that's the ability to detect pancreatic cancer DNA in the blood. And this is going to be the future of the treatment and detection of early cancer in the future. So do look out for that. And other hopes are CAR T cell therapies and novel targets. And I'll finish with this last slide. I know I talked a lot. Some resources are PanCan, like I mentioned, clinicaltrials.gov. You can search for all types of clinical trials for not only pancreatic cancer, but any disease. We talked about academic medical centers and support groups. And I'd like to say thank you and see what questions you have. Okay. All right, so the next question that I ended off with, Pastor Rhonda asked, how do you find out about clinical trials? Yes, so clinicaltrials.gov is if you wanted to look at clinical trials all over the nation. Academic centers generally do clinical trials. Community practices, they may have some, but the most you'll probably find is like at big places, academic places where teaching is happening, because usually they're trying to advance the field. Another thing I should have put on that slide, now that I think about it, is what we call NCI designated places. Those are hospitals that really have a special designation from the National Cancer Institute, so NCI, and they do a heavy amount of research. So NCI designated cancer centers. What suggestions do you have to increase the enrollment of patients in this type of clinical trials? Yeah, that's so difficult. I think the best thing that I can do, me as one individual as person, is to continue to speak at events like this to keep people aware and decrease the stigma associated with clinical trials. But I think we all could, do something about that, and just really just educating ourselves, because there's so much stuff online. But getting out in the community, and I feel it's also the duty of like community centers and academic medical centers to really reach out and make sure that their communities know about all the resources available to them. Okay, the next question was told a month ago, my A1C was very high, and that was unusual. Should I get another test or get involved in your research? Yeah, so I definitely think that if I guess there's more questions to really answer this, give you the best advice. But I would definitely follow up with your PCP. If you have any other questions, maybe I can just leave my email in the chat and see what best might be for you. If your question is about, looking for early detection of pancreatic cancer, if you're concerned about that. Next question is, what are the best options for early stage tumors, surgeries, radiation therapy, or combinations? So yes, the one thing I wanted to stress the most is that pancreatic cancer is a systemic disease. So everyone needs some chemotherapy, if possible. Everyone needs it. Because the rate of recurrence, about, like I said, 2.5 years is the average most people live after they get their cancer out.
Wow.
So we have to use the chemotherapy to kill off as much of that microscopic disease, the cancer we don't see. So we generally start off with chemotherapy up front to make sure the cancer doesn't spread. And then we pursue surgery. We sometimes do radiation in specific instances, and that really depends on if we do it before surgery. That kind of depends on the surgeon. Sometimes we do it after if there's positive margins or any other concerning features. So it is a combination, and it's generally both chemo and surgery for almost all patients. And are there any cases that a surgical procedure could be a better option than the other two? I'm not sure what was meant. Maybe I answered the question with what I said. If not, please feel free to answer and respond in the chat. If cancer can be detected in the blood, is there something that is a flag in a CBC? Yeah, that's a great question, because I hear that all the time. Like, I've been going to my primary care and I get blood work every 6 months, and they didn't tell me anything was wrong. And yeah, it's a special test. It wouldn't be in a CBC at all, unfortunately. Yeah, it's not, the circulating tumor DNA, like I mentioned, it's something that's going to be upcoming in the future. First, we have to understand it better and make sure we know what to do when we see levels are high. Yeah, we don't always, we can't generally pick it up with like routine lab work.
Okay.
Hiccups, yes, that's a good question. So I'm not sure specifically what your dad had, but people get hiccups when their liver is enlarged, because it presses up on the diaphragm and they'll get hiccups. So I don't know if he had liver involvement or anything like that. Yeah, generally it's usually some type of abdominal pressure pressing up. Next question, what made you interested in focusing on eliminating cancer of the pancreas? Do you focus on any cancer treatment? Great question you asked. Yeah, so when after I did my training, my fellowship training in hematology, so that's study of blood cancers and oncology, I was attracted to GI cancers. So I do treat actually all GI cancers, but I do spend 80% of my time treating pancreatic cancer. And I think it's just a disease that resonated with me and being a Black physician and really wanting to make strides in a disease that affects Black people the most, and a disease that in general, like no matter what race, really the prognosis is terrible, right? So there's so much work that can be done, and it's something where I felt like my heartstrings got pulled a little bit. So I don't know if I have a fancy answer. It's just I really have a passion and heart for it. And I think there's a lot that can be done.
Wow.
Any other questions?
Dr. Rogers, this has been, you want to stop sharing your screen?
Okay.
This has been a marvelous presentation. One of the things that drew me to a pancreatic project in the Care to Citizen Scientist program was the fact that every time I turn around, I hear anyone with pancreatic cancer passes away. However, I have a dear family friend who is a prostate cancer survivor and now a pancreatic cancer survivor. And that just made my heart leap. And so since if something can be done, now I'm hoping that it was the fact that he was under doctor's care is what helped catch it. Because, we cancer survivors, we usually, our blood pressure goes sky high when we have to go for those follow-ups. And it just makes you nervous. But when they go in and they find it, one of my prayers now is, dear God, find it and fix it. That's it. Whatever it is, just find it and fix it. And him being able to go to the doctor, being under doctor's care, and them identifying it. And when he came back and said they found it early, I said, wow. And he's a young man. He just turned 50, and to be able to find it, and now he is cancer free. So it's a good thing. So that's what drew me to the pancreatic conversation. And Celebrate Life Cancer Ministry is an organization that supports all cancer types. So for us to be well-rounded in the knowledge that you have shared with us today is just absolutely marvelous. So much.
That's great.
Lady Angelia, did you have a comment?
Okay, good. Good evening again, everybody. I was saying the same thing because everybody who I heard of spoke about pancreatic cancer, they did pass away. So I just wanted, I thank CARES to UF and the University of California for giving us the Care to Scientists the opportunity. And thank you, Dr. Rogers, for answering all those questions. It did answer a lot of questions. I'm definitely going to continue to share this information, not just for tonight, but I know it was some of that would like to have been on and couldn't be on. So, and I'm glad it was recorded. So, with your permission, Doctor, would it be okay if we continue to share this?
Yes, that's fine.
Thank
Also,
you.
can I ask a favor of you all? I'll probably maybe send it out tomorrow. I have like a little evaluation of myself, so that, I just want to do, make sure that, again, like I told you, my goal is to really spread the word and make sure I educate as much as I can. So like a little evaluation. I don't have it prepared tonight. It's been a long day. But if I can send it to you tomorrow, you can send it out to everyone.
Awesome. We can do that. And I also dropped in a handout that is in both English and Spanish on just pancreatic cancer awareness for anyone that may need to have something to share, something structured to share. So we would like to thank you, Dr. Rogers, for you taking time out, taking time out to breathe at the end of your long day to share with us and impart this information. And I'm sure this won't be the last time you hear from us.
That would be wonderful.
All righty. And thank you everyone for joining us, and we'll see you next time.
Amen. Everybody have a good night and stay safe. Thank you, Dr. Webb, always. Thank you, Brooke.